Dr. Mandeep Sidhu from Albany Medical College, Albany Medical Center, and Stratton VA Medical Center in Albany, New York. Had the pleasure to present data from Dartmouth Hitchcock Medical Center on behalf of colleagues from Dartmouth today on the indications and survival of patients with coronary angiography in the nonagenarian population. We discussed the importance of understanding this previously understudied population of patients over the age of 90 who are the fastest growing segment of the Western population and projected to be approximately 18 million in population by the year 2050. Currently, elderly patients over the age of 75 comprise 30% of acute coronary syndrome patients in presentation. We performed a prospective collection of 147 consecutive patients at Dartmouth Hitchcock from 1995 to 2011, in which we then analyzed the data further to better understand both their indications, their periprocedural morbidity, their in-hospital mortality, and their long-term survival following coronary angiography with or without PCI. We found that the patients were predominantly presenting for emergent or urgent indications, with 25% of the population presenting for ST elevation, myocardial infarction, and another 25% of the population presenting for non-ST elevation MI. Only a minority, approximately 17%, were for elective procedures. The patient population also revealed a preponderance of females, approximately 61%, and a large percentage of patients with comorbid conditions such as heart failure, hyperlipidemia, and hypertension, reflecting that this pilot study was indeed a real-world cohort of patients. The average age was 92, with our most elderly patient being 97 years of age. We also found that the procedure type was a preponderance of patients who underwent PCI, with approximately 75% of patients undergoing PCI and 25% undergoing angiography alone. Of the PCI population, we found that roughly half of the patients received drug-eluting stents and half received bare metal stents. And our final results also depicted that the periprocedural morbidity was most common with any bleeding requiring transfusion in approximately 1/4 of patients, and 10% of patients having contrast-induced nephropathy, and another 10% with vascular access complications. Understanding that this study performed between 1995 and 2011 was largely a reflection of femoral access and not as much radial access as currently is being practiced. In terms of long-term survival, we found that the in-hospital mortality was 9.0%, but the long-term data as assessed by the Social Security Administration Index Death Master File revealed a median survival of 2.8 years with a range of 0.7 to 5.1 years. This was particularly interesting to us as the CDC actuarial life estimate tables have reflected that the average patient at the age of 92 has an average expectant lifespan of 8.7 years, which was quite surprising to our group. However, upon further reviewing the literature, it seems to make perfect sense that a patient who has self-selected themselves to the age of 92 has the genetic predisposition and substrate to make us believe that they would have a longer than average lifespan. And therefore, our results with an average median survival of 2.8 years in relation to that of the 8.7 years for the average 92-year-old without cardiovascular disease seems fitting. We have concluded that this is a very important retrospective pilot analysis. However, it begs the question of why there is not more data in the nonagenarian population. Clearly, there's a a great deal of need for further investigation, and larger scale outcomes data would be very helpful in determining the best therapy for this patient population, as it is undoubtedly going to grow as the population ages at large. We also noted our limitations of both being a single center study as well as having a modest sample size. However, our greatest limitation was that we could not account for differences between the invasive evaluation and therapy with angiography and PCI as compared to a conservatively managed group with medical therapy. And that would be the next phase of our investigation, as we believe the comparison is absolutely critical, first in a retrospective fashion, and then prospectively it is essential that we have randomized data to better understand how these patients can be optimally treated, whether that is invasive or non-invasive, and that should be determined. On behalf of all of my colleagues, both from Dartmouth-Hitchcock Medical Center and now from Albany Medical College, I'd like to thank the organizing committee, the chairs, Drs. Balmer and Birnbaum, for inviting us to share our data here at the 18th World Congress at the International Academy of Cardiology. And I would particularly like to congratulate Professor Asher Kimchi and the entire organizing committee for putting together a wonderful program of the best and brightest scientists and clinician researchers from all over the world, as this meeting has been truly international and brought together many different collaborators and colleagues from all over the world, not to mention picking a wonderful site here in Vancouver, British Columbia. I particularly look forward to the International Academy of Cardiology and the World Congress celebrating its 19th annual World Congress in Boston, Massachusetts, as that is my hometown, and welcome all to come to Boston next July, and hope to see you there.